Good evening, viewers. My today topic of presentation is brachytherapy role in clinical oncology. Although the role of brachytherapy day by day declining due to advent of electron therapy of a linear accelerator, but there are few tumors. The brachytherapy is still a gold standard. There is no replacement for that. Like in the soft tissue sarcoma, interstitial brachytherapy, or a carcinoma cervix brachytherapy, there is still a gold standard. Nobody can change till now. So regarding the brachytherapy, the historical prospects, the Bell in 903 first suggested the implanting the radioactive source directly into tumor may lead to a better result, but the same thing was a term, but brachytherapy was coined by the Forshell in 1931. Forshell has coined the term brachytherapy. So initially the radium was used as a brachytherapy in very initial days, but the sooner they have realized that the byproduct of radium is a radiotoxic, radon gas emission was always a threat. Contamination can cause a great problem because a contamination because of a large half-life, 1600 almost 30 years, can lead to a major disastrous problem. And then another problem was associated with radium was a low specific activity. Activity per gram is considered as a specific activity, means that we used to have a very large source size, so it was not negotiable with the catheter to pass this thing. So then another problem was associated with the high cost, and then because of a large half-life, the disposal was a real problem. Due to so many problems was associated with the radium, but the radium was practiced in the certain time as a brachytherapy source, but because of above problems, the that leads to the discovery of many other radioisotopes currently in use. So what should be the ideal brachytherapy source? The ideal brachytherapy source should be preferably a gamma emitter, an energy ranging around 200 kilo electron volt, preferably monoenergetic. That is the very good if it is a monoenergetic, a fairly large half-life for a temporary implant, and fairly shortest half-life as where we use as a permanent implant. Permanent implant means we need not to remove after that implantation, because the shortest half-life will make the no use of that thing of a radioactive source, and then it will be the inactive component will remain there in tissue. And there should be no gaseous byproduct, and a high specific activity means activity per gram should be very high, so that a very miniature source can be developed. That source should also be insoluble and chemically non-toxic, and should be molded in various shape and size, so that we can acquire the geometry of a tumor after the implantation, and should be also low cost. So brachytherapy sources are available in various physical forms such as needle, tubes, pellets, seed, wire, which facilitates their application in the patients. What are the forms of application of a brachytherapy? Brachytherapy can be used as an intracavitary, interstitial in the tissue itself, intraluminal like in a bronchial, like in esophageal, surface mold like brachytherapy can be used as a surface mold on the skin tumors, preferably after making a mold. So like you see the mold, this side niblet prostate template was designed beautifully by this scientist, and then we can go for the prostate implant after putting it on the perineum, and then you see the cardboard template that used here for the tumor of floor of the mouth or a lip tumor. We have details of here the isotope, what is their half-life, average photon energy, and exposure rate constant, that is the Roentgen centimeter square per millicurie. I mean, the one Roentgen definition of Roentgen is important. One must remember this. So for that specific purpose, we should. I'll tell you about the cobalt is also used as a HDR brachytherapy source. The half-life of 4.26 years and average photon energy, we all remember it's a 1.25 MeV. The iridium, which is a interest of source, half-life is 74.2 days, average photon energy is 0.38 MeV, and then you also see the iodine 125, half-life is 60 days, average photon energy is 0.028 or 1.028 exposure rate constant. So these are the things which is very important. You see here the gold half-life is only 2.7, and podium 105 is a 70 days half-life. I mean, the gold is used for the permanent implant because of a shortest half-life I've discussed to you earlier. Like a malignant pleural effusion, malignant ascites, this gold can be used as a permanent uh, implant. So here in the diagram you see the source strain manual after loading. You see here in the tissue the wire is stellate is passed as just like an intracath. You put the stellate with a tube, and then you remove the stellate, the catheter inside there, and now you fix with a nylon ball on either side of the tumor with a lead disc, and then after that you put a dummy wire and get a check X-ray done, and after that you connect this uh, applicator with a source drum, and then you on the switching on the source, the source comes and goes through this um, nylon tube, this, and then deliver the radiation. So that the train, I'm telling you what about train about this, that the is not that the source is there, and then multiple sources. There are only one source. I mean, and there is spacers in between the source are there. That miniature cylindrical sealed sources are there, and then the spacers in between. So these are the source miniature source train assembly is like this. The sources I've told you, the cobalt 60 available in form of needle tube pellets for HDR after loading, and then also cobalt is used in the teletherapy is very popularly. The cesium 137 is available in form of needle tube beads for after loading, and the cesium is quite high used as a LDR brachytherapy source, and then half-life of the cesium was 30 years. Iridium 192 as a wire pins for manual after loading, as a pellet for remote after loading. So for the if somebody asks you in the after loading source of iridium is what, is basically a pellet. Now wire and pins are used as a interstitial implant. Iodine 125 sheet for permanent implant for surface application. The cesium 137 is largely replaced by the radium initial days as a nucleotide of a choice. The reason is the alkaline material of a cesium, like a cesium chloride or sulfate, was chemically stable, and the cesium was having a recommended working life of 10 years. That dear friends, I just want to stress upon that do not get confused with the half-life with the strength of a source, because in the radioisotope source the manufacturer gives a working half-life of integrity of a source. Like in the cesium, half-life is 30 years, but the recommended working life is 10 years. So all the sources have a recommended working life beyond which the manufacturer will not guarantee the integrity of source. So why it is happened? Because the source, when this travels through the source drum to the tube to the catheter, so that get a mechanical damage, and then the source up to the certain period of a time which is being given by the manufacturer, that the source can be used up to this years. So here the cesium, like it was working half life is different, is 30 years, but the recommended working life of a source is 10 years. So cesium is available in form of needle or tube or a small pellet for a remote after loading machine. So was quite heavily used cesium as a LDR treatment for brachytherapy cervix. The iridium 192 currently widely used because of a high specific activity, because of flexibility of its wire pin, acquired the shape of a geometry of a tumor, and the iridium sources are available as much as thin like 0.8 millimeter diameter, and after the encapsulation of a source encapsulation is comes to around 1.1 millimeter diameter, and then a length of active wire is 4.5 millimeter in length. The gold 198, iodine 125 can be used for a permanent implant, gold 192 because of a short half-life, and iodine 125 can be used for the surface or mold application, and both of them are replaced quite heavily by the electron treatment of LINAC. So that's why I was telling that the LINAC has quite very high replaced the the brachytherapy, but 2-3 tumors you don't have a choice except to go for a brachytherapy. Electron cannot be worked there. The rate of electron is not sufficient to give you a total tumor control on that area. So cobalt 60 high specific activity and high specific gamma ray constant make its attractive use of high dose rate, high HDR brachytherapy source, and a gold 198 available in a grain, seed, and wires with the help of implantation gun directly fitted in the tumor area, used as an implantation gun, use implantation purpose. Also, it is quite useful in the malignant pleural effusion and malignant ascites. Iodine 125 available in form of seed or plaque as a permanent implant and directly applied to the tumor area, particularly is a treatment of choice in case of a single solitary retinoblastoma less than 4 millimeter in size, is quite heavily it is used. And the practical aspects of a brachytherapy, activity of a source is a basically apparent activity because the real activity of a source is attenuated because of a source encapsulation. No source is supplied as a naked source because the source has to be encapsulated with a lead shielding, and thus the true activity is always greater than this activity. So one must remember the exposure rate constant, gamma ray constant, is defined as the dose rate in a centigrade per hour at a distance of 1 centimeter from 1 millicurie activity of a point source. This is, however, redefined because of a source encapsulation attenuation effect. So if a source of 1 millicurie at the distance of 1 centimeter as giving a dose rate of in centigrade per hour, that is its exposure rate constant. From a single source point, a gamma ray is emitted isotropically. The gamma ray emitted isotropically means in all the direction the single point source gamma ray emitted. It follows the inverse square law, therefore intensity of radiation will decrease with the square of a distance from the source. That is called inverse square law. So that inverse square law quite effectively and heavily is there in the brachytherapy. In the teletherapy, the inverse square law is less effective, but in case of a brachytherapy, the inverse square law is very effective because the dose rate fall is in this range is very rapid. So the dose rate fall in the rapid, that is taken as an added advantage, that the rapid fall of the dose beyond the tumor area, which is not required to give a radiation in the brachytherapy. The dose rate will be proportional to the activity of the source as well as inverse square of the distance from the source. Like in a figure, I'll say you the 5 equally spaced line of a source Each emits gamma ray in all directions, producing the complex pattern of isodose distribution. Because each will emit isotopically all 5 sources, so it will produce a complex pattern of isodose distribution. It has been seen the point close to the source in the same horizontal axis will receive a high dose, and a point between the two sources will receive low dose. How? I will show you in this figure. You see the equally spaced 5 sources, and between the two sources, the activity is lowest, and then the same, in the same area point just in the horizontal axis of the source beneath, the dose is very high. So you see the curves here, the dose, and if you go by the distance, as the longer the distance, you see the curve is bent like concave. I mean, both the terminal ends of that area will receive the lesser dose, and the center will receive the high dose. So how we adjust, I'll explain you. The uniformity of a dose achieved depends upon the both distance from the source and the spacing between the source. Uniformity of a dose further improved by increasing the activity of source at the end of line. You see here in the figure 14.1, in the 5 equally spaced source and then a pattern of isodose line, but on the top, the lowest line, you see the curve, and then is this curve is indicates the high dose in the center by joint effort of all 5 equally spaced source, and the lowest at that same area, so that if we increase the dose in the end of both the terminal sources, activity increase, then we can get in a horizontal the uniform dose distribution at that horizontal level, which is our intention to get it. So what are the methods of application of a brachytherapy? That's a preloading method, manual after loading method, and remote after loading method. The preloading methods, the source are loaded in applicator before they are inserted into the patients, and because of a radiation exposure to the medical paramedical staff lead to invention of after loading methods. Then manual after loading was what? That the first the applicator in the patient applicator put in the patient, then the source are manually inserted to the applicators that have a lesser chances of exposure rather than the preloading method in compared to. But after both the preloading and manual after loading was removed heavily when we discovered the remote after loading devices. Then each applicator is fixed in the patient, check X-ray is carried out, localized dummy source in the applicator and the check X-ray done, and then we connect the catheter to the source drum and then put the switch on, and then a remote after this. So almost eliminated the radiation hazard to the medical and paramedical staff. And because of preloading and manual loading, the threats, and because of radiation threats, so because of that, they used to do in a hasty fashion, and then the source application, check X-ray, everything was not enough up to that mark. But in the remote after loading, that everything was in a planned according to our choice. So the source movement, the combination of various source strain with the option to choose a small miniature source with a spacer, enabling the operator to create its own source configuration. Because increasing the dwell time, we can increase the design the shape of the radiation area. So according to that, we can plan the tumor by this source. By single source with the option of a different dwell times, means once one area is given a different time to deliver, some suppose 2 seconds, some areas to the 30 seconds, some area to the 90 seconds, the various position that can create, and the various, like you can use as the various sources position simulating as a single point. So that is the beauty. Is this in this figure you can see the optimization of a dose distribution. This is called optimization. You see here in the three sources in the first figure, and then each sources is delivering that area radiation. But if you can adjust the dwell time, this you can give a linear one single line of a radiation area. You can increase further. You can top source and the bottom source increase the dwell time heavily and reduce this dwell time very minimal in the center. You can get like a third figure dose optimization, or you can increase the dwell time of a first source very high, and then medium to the middle and the lowest to the bottom source. Then you can get the pear shaped the dose distribution. This is called the optimization by using the beautifully the dwell time of the source. So let us talk about the some clinical interesting points. The interstitial implant, it is important to clarify, define target volume first, and have a pre-planned number and a distribution of radioactive sources to be used. Homogeneous dose distribution is very important because high dose around each source can cause necrosis, and a low dose between the two sources could result in the cold spot, and that will lead to the recurrence. So this we should keep in the mind. The brachytherapy in head and neck cancer, actually little bit I'll talk you that a T2 lesion operated develop a recurrence as a node, and that node on the MRI shows a extracapsular spread, and the primary is well controlled. And if you give a result, give a radiotherapy by external beam radiotherapy, is basically will result will have a poor result. But adding the interstitial brachytherapy in this particular situation, neck node failure rate decreased from 50% to 20%. By giving a EBRT, the failure rate is almost 50%. Patient will failure, neck failure rate. But if you go interstitial implant, it's 20% failure rate. So this is the brachytherapy, interstitial brachytherapy used in the head and neck cancer. Sometimes the brachytherapy also used in a soft tissue sarcoma. We can use the soft tissue sarcoma post-op case. If you want to deliver the brachytherapy after the external beam radiotherapy as a boost or as a primary treatment, we can use the horizontal implant or a vertical implant, both. The vertical implant requires more number of catheters, and the chances of a neurovascular injury during the implantation is high in the case of a vertical implant, because you are vertically entering. So that the more popular is the horizontal method. Between the two catheters, the distance should not be less than 1 centimeter in any situation, or should not be more than 1.5 centimeter in any situation. The low grade soft tissue sarcoma brachytherapy used if size is more than 5 centimeter, or if a recurrence is there, and dose is recommended is 36 gray in 9 fraction is used. And during the implant catheters, the care must be given to protect the neurovascular bundle. So the spacer has to be used with the implant, and between the neurovascular bundle, the gel foam or a spacer is used. That is the shortest brief I can give you about the role of brachytherapy, interstitial brachytherapy in soft tissue sarcoma. So let us talk about what are the rules of interstitial implant. The active source should be parallel and straight. Line should be equidistant. Line or a plane which the midpoint of the source lies should be right angle to the axis of the source. This is very important. The plane on which the midpoint of the source lies should be right angle to the axis of a source. Linear activity of the source should be uniform along the length of each line. Separation between the source may vary from implant to implant, but a minimum 8 mm separation is acceptable for a smallest volume, and then for a maximum volume, the 20 mm separation between the two plane is recommended. The average length of active wire should be larger than the target volume, because I've told you that the corner area of the two ends in the figure, the dose rate drop down, so that you get a homogeneous dose distribution in the plane. We required the larger than the target volume. The active wire length of active wire should be larger than the target volume by 25 to 30%. So this type of implant, single plane implant, loop implant, you can see, and the single plane implant you see here in the CA lower lip, a single plane, and the loop technique. The interstitial brachytherapy in the carcinoma cervix has a role, particularly the MRI based and the CT based brachytherapy as a IMRT or conformal radiotherapy is practiced, but these are justifiable, in particularly in case when the tumor has a post-op CA cervix recurrence and the tumor geometry is such that it is not uh, medically amicable to put an implant by the traditional traditional catheters inside the cervical canal, or on the side of the cervical canal, so that we delivered the interstitial brachytherapy, and then CT MRI compatible applicator is there. Then you put the implant, get the CT scan done, and then get the tumor dose dose rate on the treatment planning system. See the target, how much dose is covered, the bladder tolerance dose should be respected, and the rectal tolerance dose should be respected, so that we can deliver the radiotherapy. The Paris system of dose calculation is on the distribution of source in the central plane, that is the plane which is right angle to the axis of midpoint of the source. First, we calculate basal dose rate, represent the dose in the center of implanted volume, and is defined as a dose rate at the point in which the middle of a pair of a group of sources where dose rate is lowest. In case of a large implant, there will be several pairs of a group of sources arranged in a triangle or square. For these, mean basal dose rate is taken. So for the first for dose calculation, find out the basal dose rate, and then with the multiple basal dose rate, then you found out the mean of a basal dose rate, and then basal dose rate is a point, is a summation of a dose contributed from each source obtained from a graph of a dose rate variation with the distance from the source. This used to be done very in early days, but now you have a very beautiful software 3D treatment planning system to solve all these issues. But just for a historical point of view, I am telling you how we used to calculate the dose. Like you see here, that three sources in a figure A, 1, 2, 3, and you find out the midpoint of all three, that is basal dose. And if you see the 4 sources are there, then you make a 2 triangles, and then midway from the triangles you find the basal dose 1, basal dose 2, and then found out the mean, that is the mean basal dose rate. Once the basal dose rate in the center of implant is defined, the reference dose is taken. 85% of a basal dose rate is taken as a reference dose rate. This serves to calculate duration of implant. Like 85% isodose rate defines the treatment volume. A value of 85% is chosen to provide an isodose contour that reasonably covers the target volume and acceptable variation between the dose at the center and the periphery of a target volume. So the time for which the implant must be left in place is derived by dividing the prescribed dose by the reference dose. You see here the 2-plane implant, the superficial plane, 5 centimeter wire, 2, and the deeper plane has a 7 centimeter wire. That is the 7 centimeter wire, and the separation between the source is 18 millimeter. The activity of source midway through the treatment, 0.5 micro gray per hour per millimeter at 1 centimeter distance. So that you see, you find out you made two plane. So into the two, I mean the multiple triangles is being created, and each triangle's contribution as a basal dose rate you found into the mean basal dose rate. After finding out the mean basal dose rate, 85% of a mean basal dose rate is a reference dose rate, and you find out the reference dose rate and then the total treatment time. How you calculate? I mean the uh, uh, total, suppose it's a 25 gray you have to deliver, so the total 25 gray into the reference divided by the reference dose rate, you find out the time, that is 16.05 hour. That is the left the in the LDR. I'm talking about the LDR, which used to have a very long time, the catheter to be left in the, I mean the source to be left in C2 2 days 13 hours for one fraction. So this is the, I mean the rationale. The rationale of low dose rate brachytherapy, it has been known for many decades. I told you the LDR treatment in the brachytherapy was very good, having a very good historical data regarding the CA cervix post-op, or even the non-operable case of a CA cervix brachytherapy. So increasing the dose rate will increase the late effect much more than it increase the tumor control. Conversely, decreasing the dose rate will decrease the late effect much more than it will decrease the tumor control. Thus, the therapeutic ratio, the ratio of tumor control to the complication, increases as the dose rate decreases. So you see here the early effect and the late effect, the importance of a alpha beta ratio. Alpha is a linear component and the beta is a quadratic component, means the square of the dose, and the dose that responds, this linear quadratic model is quite very suitable for the LDR treatment of brachytherapy. So dose rate and ICU RU38 recommendation, you all knows ICU RU38 defines the LDR 0.4 gray to 2 gray per hour, MDR 2 gray to 12 gray per hour, HDR is more than 12 gray per hour if you are delivering, that you categorize these things. Most of the LDR and MDR, the cesium 137 as a source, and HDR is iridium 1 and 2 cobalt 60 was a source. So, some clinical dilemma here. The treatment technique must be described. The ICU the recommendation given by the ICRU. The treatment technique must be described. Reference volume should be described in terms of a height, width, thickness of the volume, enclosed in 60 gray isodose of LDR treatment in the CA cervix. Why they have ICRU 38 recommended? But even like in the CA cervix, traditionally cervix is an anti-verted anti-flex. So the point A is not get disturbed. Point A is you have know that the os marker 2 centimeter above on the lateral is the point A, where you are intended to deliver at 285 gray. But if the cervix is retroverted retroflex, what will happen to the point A? Point A will change. So the point A will change, the dose calculation becomes different. So for a conventional purpose, that they have described the ICU route in the terms of a height, width, and thickness of a tumor volume enclosed in the 60 gray isodose is called reference volume. So the abdominal dose at a bladder reference, on a rectal reference, lymphatic trapezoid point, and a point A and point B, as well as the dose determined on the computer to add extra dose to the website area. So you see this electron, now it's obsolete almost. You see the conduit from which the catheters are going out in the treatment room. The source drum is here, and you see the lady with all the applicator fixed, and then the catheter is, urinary bladder is catheterized, and you can see the marks of the external beam radiotherapy on that lady. And then this is the way we used to deliver the LDR treatment of brachytherapy in CA cervix. So that I've already told you regarding the point A and point B system, but some clinical points also there, that you see the tandem is usually a tandem is the central tandem precisely is tilted towards the anteriorly. Why not posteriorly? This is tilted because the cervix position is like anteverted antiflex first, and the second is the bladder tolerance dose is little higher, that is almost 65 gray, in compared to the rectum and sigmoid colon tolerance dose, that is almost 60 gray. So the dose and the received here is anteriorly, if it little higher, is not a big problem, but if it dose exceeds then the rectum and sigmoid, they will create a problem. So that is why this has tilted. So what is the take-home message for the brachytherapy? The brachytherapy planning required a military discipline. Radiation oncologists must be fully aware of each and every applicator and about its dimension and its length. Tip of applicator and a first 12-point distance must be very clear. The distance traveled by the source from the catheter tip to the first 12-point is called indexure length, should be very clear. After the implant done, the CT is ideal to acquire the image. On the CT image, we do the target volume delineation and deliver the treatment according to the tolerance dose. Thank you very much. Good evening as well.